My name's David. I'm a GP in Llangefni. I've been a cluster lead in Anglesey for a few years, and now I'm one of the primary care leads for the planned care team. We're supporting with writing EMIS searches and templates for the QI projects this year, partly because we've got a long experience of writing EMIS searches and projects for QI, but also it's to support the implementation and spread of the community health pathways, which you'll see are being referred to particularly in the CKD QI project. These are pathways that are agreed nationally between GPs and the national clinical networks. The idea then is that they're going to base these on the best evidence and appropriate evidence for Wales, agree a pathway and a guidance for Wales, and then these are all localised in each health board by a team of GPs and local consultants to make sure the pathway is relevant to you, but also has got all the useful links and information, phone numbers, websites, advice on who needs referring and to where in your locality. And it's far easier than endless posters, lots of different web links, everything's in the one place and easy to access. I am a big fan, which is partly why I'm involved in the project. Now, this is the third video. We've already done a video looking at the CKD and the cardiovascular disease prevention. The reason I've pulled in diabetes is we found almost immediately that a large number of our CKD patients, when we were looking at flows in eligibility, were diabetic, and there's a big overlap with our hypertensive group, our cardiovascular group, and we felt it might be useful to take a cardio-reno-metabolic approach to this issue. If a patient has CKD and diabetes and or hypertension and or cardiovascular disease, I'd quite like to be looking at them holistically. The other reason to look at it in this way is because of our initial concerns over workload. We felt that there may be high numbers of patients that we suddenly need to chase and manage and monitor, and mild disagreements about workload and contractual obligations, but actually what we found is most of them are diabetic. In our diabetes and CKD folder, there's a folder for comorbidities, and you can see that about 25% of my CKD register have established cardiovascular disease already. 30, in addition to that 30% have diabetes, and overall, almost 2/3 of my CKD register have got an HbA1c greater of 42. I've got a small number who've never had an HbA1c, so we're changing our processes to make sure that doesn't happen. We should be screening for HbA1c in CKD. And then 26% are hypertensive or likely hypertensive. So you can see that about 30% are diabetic, 25% cardiovascular. That cardiovascular group includes some diabetics as well. But because the management of this group is already more aggressive, we're separating them out slightly. 25% are hypertensive or should be coded as hypertensive, and 25% pre-diabetic. So the overlap in comorbidity is very high, and I felt that for this project, particularly if we're trying to look at how we recall, monitor and screen this population and best manage them because they're all very high risk cardiovascular events, I felt we should pull in diabetes. Part of our assurance framework this year is looking at the percentage of patients who've had all 8 diabetic processes, and those familiar with EMIS may well know that we don't have inbuilt searches at the moment for those 8 processes. Yes, they're available in Audit Plus, yes, they're available on the Primary Care Information Portal, but you don't have them in EMIS, and unfortunately what that means is you don't have the prompts when you're seeing the patient. So for example, ACR is one of the first inactivated QOF indicators, and we lost the prompt for that. We lost the prompt for encouraging us to consider ACE inhibitors for ACR over 3, and I think it's been an unintended consequence of those changes that has led to really quite poor national numbers. And I felt it was useful to share our searches on those 8 processes so that you can see them for yourself inside your system. Now, we're looking at flows in eligibility in CKD, and we're looking particularly at ACR capture. Now, flows-ins obviously play an important role in diabetes too, which is where most of us are familiar with their use. NICE, I gather, was very close to suggesting Flozin with metformin first line, but certainly wants us to consider Flozin for established cardiovascular disease or for Q risks of greater than 10%. And it's always worth noting Q risk 2. In my other video, I do talk about using Q risk 2 versus Q risk 3. Flozins appear to confer significant reductions in cardiovascular disease events and end-stage renal failure, regardless of what they're doing to your HbA1c. So the diabetic searches show you your 8 processes. They look at the treatment targets for the assurance framework as well. All targets met. TT07 means HbA1c under 48, cholesterol under 4, and blood pressure under 140/80, which is quite aggressive management, which is why I think most people's numbers for that are quite low. The searches for diabetic medicines, whenever we're doing searches, in these searches at least, to say consider things like statin, we exclude people who have adverse codes or have had them before and stopped, and the same for Flozins and ACEs. And so occasionally, if you're familiar with how we build searches, we do a lot of use the results of these searches in other searches, but it's an aside. When we're looking at eligibility for things like ACEs and Flozins, then what we're looking at is things like diabetics with ACR over 3. These should be on an ACE. I have 122 diabetics with ACR over 3. 50 of them are not currently on an ACE without any adverse or declined codes. So there's a bunch of searches where you can look at to see how you are for each particular drug. Same for things like statins in diabetes. In general, I have very, very few diabetics over 50 with Q risks of less than 10%. We do a lot of Q risking, and we automatically Q risk quite a lot of our patients when we get our lipids in and things. So I know that I can rely quite a lot on my Q risking, but a lot of places might have less Q risk uptake. This will look for those with Q risks over 10% or age over 50 or already established cardiovascular disease and eGFR under 60. So these are the diabetics potentially most likely eligible for statins, which is around 425. 300 of mine are on statins, but 100 aren't. So again, there's another area we might be saying we should be targeting statins in these 100, ACRs in these 50. And we've done similar searches for Flozins. So if you're diabetic, and again for the Flozins, we exclude type 1 diabetes in these searches. We exclude those with a history of DKA. We exclude people who've had Flozins before and stopped. There is a code for adverse reactions to Flozin. There isn't a read code for Flozins declined, so we can't exclude those. And it's worth being aware of that. The reason we exclude those is we're trying to find the numbers we particularly feel we might want to target or chase at the moment. So we should be considering Flozins in those with established cardiovascular disease. I'm looking for patients with HbA1c over 58 who are on less than 3 oral medicines where they aren't on a Flozin. You'd argue we should be trying to hit them to target. And again, I know these are people who haven't been offered a Flozin before. Those with heart failure and type 2 diabetes, I appreciate that the guidance is Flozin if they're symptomatic. But again, I think if you've got diabetes and heart failure, you might well say it's established cardiovascular disease of a form, and we should be considering Flozin there. Those whose ACRs are over 3, they're eligible for ACE, and we should also be considering a Flozin. And then we've got those who have a Q risk greater than 10%. Again, if we go back to that nice flowchart, which is suggesting that Q risk higher than 10%, we should be considering Flozin as soon as metformin tolerability is confirmed. Now, I appreciate that the QI project is a focus on CKD, and I suspect that's partly because of the lack of awareness of the benefits of Flozin in CKD, and also the concern about the lack of ACR testing in CKD. But we looked at diabetes partly because when we look at our CKD register and find that about 100 of our CKD patients could be considered for a Flozin, what we find is that around 186 of our diabetics could be considered for a Flozin. Now, I'm not suggesting that we go out there and start everyone. I think each patient still needs individual consideration and review. But when we look at diabetes and CKD combined, what we find is that the numbers are 256. So the numbers of diabetics that we should consider are 186, and it's an additional 70 if we're pulling in CKD. And I have looked at that 70, and what's very clear from that group is a lot of them are pre-diabetic, and some of them have never had their HbA1c checked. And I am going to chase that. I think we need to make sure that we're getting up-to-date HbA1cs and regular HbA1cs in that group. I suspect the overlap is greater still. When I do audits looking at my diabetic population and looking at things like their Q-risk scores and their eGFRs, 90% of my diabetics have either an eGFR under 90, so at least mild impairment of renal function, or a Q-risk of greater than 10%. And I think when we consider the fact that the Flozins are so cardio-reno-protective, I can see why there is an increasing push to really consider early Flozin use in our diabetics, with organisations like NICE endorsing their use increasingly because of the high value in reducing cardiovascular events and end-stage renal failure. Yes, they're expensive, but nowhere near as expensive as the cardiovascular events and the end-stage renal failure they will prevent, and of course the impact that has on individuals and on health and local authorities and social care in the future. I'm also slightly bothered by my lack of ACR capture in our diabetics group. We've got 464 diabetics. I still have 180 who haven't had an ACR done, and we need to look at this. This is one of our main reasons for not hitting our 8 processes, as well as foot checks actually, but that's difficult because of the whole capturing everything as we go, and I'll come back to that in a separate video on proposals around catch-up. I've also put in a search on the AF Stop a Stroke. Again, this is in your assurance framework. There have been various projects over the years, but this is looking at our AF register who are anticoagulated if their CHAD score is 2 or greater. And then we're looking in particular for those who haven't had a CHAD score. This is quite low, but ideally that should be near to 0. And we're looking for those who aren't on anticoagulation, whose risk is 2 or more. So I have 11 of those patients. I can see that 8 have declined anticoagulation, or that it's been stopped or not indicated, but there are 3 of my patients here that I might want to chase and check. Now, what I've found with those is we've often not coded that they've declined or not indicated, or there's been a reason they've not been started on coagulation by the hospital. Although this also, CHAD scores will go up over time. So if I imagine these CHAD scores under 2, age and other comorbidities will increase that CHAD score, which is partly why we need to review them, keep an eye on them, and see, hey, do we need to be anticoagulating some of these over time? So this number will always be there slightly as your population increases in risk. So in summary, there's searches to help with your 8 processes. The search is showing you which of your diabetics you might want to consider review for things like ACEs, Flozins, and statins. And there's also blood pressure not to target. This search is showing the overlap between diabetes and CKD. I didn't show, but there's 127 patients out of both registers who we should be considering for an ACE, and actually it's 126 those are diabetic. So the overlap is very high. Yes, there's 13 of them in the CKD group, but what that means, 12 of them are diabetic. And then a few searches for the AF, just because it's part of that cardiovascular disease prevention. In fact, it's one of the biggest, easiest wins. Anticoagulating people with AF massively reduces stroke risk, as we all know. and I'll create videos to show demonstrations of searches to look at your current catch-up numbers and suggestions on how we might want to recall these patients going forward.